Welcome back to Neurology 101, where we continue exploring cranial nerve syndromes. I'm Dr. G, and today's episode covers trigeminal neuralgia, also known as tic douloureux, a condition that brings electric shock facial pain and board questions alike. Let's dive in. Did you know the term tic douloureux translates from French as painful spasm? Patients often wince or grimace with pain, sometimes resembling a facial tic. It's a disease so intense, it has historically been dubbed the suicide disease due to its severe, unpredictable pain flares. Let's look a little deeper into the Kinder Patho. What is trigeminal neuralgia? Well, trigeminal neuralgia is a chronic neuropathic pain syndrome that affects the trigeminal nerve, cranial nerve 5, the nerve responsible for facial sensation and some motor function, like chewing. It's most often caused by vascular compression of the nerve root near the brainstem, causing demyelination and aberrant signaling. Other causes can include multiple sclerosis, tumors, or postherpetic changes. The hallmark is recurrent unilateral sharp stabbing pain in the distribution of one or more branches of cranial nerve 5, most often the V2 or maxillary or the V3 or mandibular branches. So, how do these patients typically present? Well, we often see sudden, severe unilateral facial pain, and it's usually described as an electrical shock, stabbing, or sharp pain. It's triggered by mild stimuli like brushing the teeth, the wind hitting your face, eating, or even just touching your face. Most often, it affects V2 or V3 branches. The attacks last from seconds to minutes, often with refractory periods. And it may become more frequent and intense over time. How do we make the diagnosis? Well, it's a clinical diagnosis based on classic description and the absence of neurological deficits. An MRI with contrast is used to rule out secondary causes like multiple sclerosis, especially if it's bilateral, and mass lesions or vascular compression at the nerve root. Consider labs if suspecting systemic causes like infection or inflammation. What about treatment? Well, first line is going to be carbamazepine. It's highly effective, or oxcarbazepine. Monitor for hyponatremia, blood counts, and hepatic function. We can also give baclofen or gabapentin as a second line or adjunct treatment. Refractory cases, there is surgical microvascular decompression. We can also consider radiofrequency ablation and a gamma knife radiosurgery. Bookmed versus street med. So the bookmed is going to give us brief stabbing pain in the face triggered by touch. It involves cranial nerve 5 and we want to treat with carbamazepine. Street med. If brushing their teeth feels like electrocution on one side of the face, it's definitely trigeminal neuralgia. Some quick clinical pearls. Pain description. Sudden, brief, lasting less than 2 minutes, unilateral, stabbing, or electric shock pain in the face. Triggers include chewing, talking, touching the face, brushing the teeth, or even cold wind. A neurological exam is usually normal between attacks. And the first line treatment is carbamazepine, but we want to monitor CBC and LFTs. Second line, oxcarbazepine, or surgical options if refractory. Imaging, MRI with contrast to rule out secondary causes like a mass or MS. All right, let's test our knowledge. So we have a 55-year-old woman who describes intermittent stabbing pain in her right cheek and jaw that lasts seconds to minutes and they're triggered by brushing her teeth. What's the first line treatment? Is it A, gabapentin, B, amitriptyline, C, carbamazepine, or D, prednisone? If you said C, carbamazepine, you are correct. This is classic trigeminal neuralgia, and we treat with carbamazepine and consider MRI to rule out secondary causes. Question 2. A patient presents with facial pain suspicious for trigeminal neuralgia. Which of the following findings would be most strongly suggestive of a secondary cause like MS or a mass lesion? A. A normal MRI. B. Pain triggered by brushing the teeth. C. Bilateral facial pain. Or D. Normal neurological exam. I'll give you a few seconds. If you said C, bilateral facial pain, you are correct. Trigeminal neuralgia is usually unilateral. Bilateral symptoms suggest secondary causes, like MS. Okay, so some final thoughts. Trigeminal neuralgia is a board favorite because it is so distinct, brief, electric, and triggered by everyday activities. Just remember, sharp face pain, cranial nerve 5. Up next, we're wrapping up the cranial nerve palsies with a review of the neurological exam itself, a vital part of any neuro assessment. Enjoying these neuro nuggets? Hit follow so you never miss an episode. And remember, this is the Pro PA podcast, where future pros in medicine are made. Catch you in the next one.